Hello, everyone. Welcome to what we're calling the Extra Life Conversations. I'm Stephen Johnson, and I'm the author of the book Extra Life, A Short History of Living Longer, and I'm the host of the PBS BBC4 series. We hope you've had a chance to watch episode 1 of the series on the past, present, and future of vaccines. If you haven't seen it, the show is streaming at pbs.org, and depending on when you're watching this, it will soon be on the BBC iPlayer. So I want to start by thanking the CDC Foundation for helping us put these virtual events together, and I'll have more to say about them at the end. I also want to thank the publisher of the book version of Extra Life, Riverhead Books, and the Pulitzer Center, which is developing curriculum materials for teaching this epic story of our extended life. It's kind of incredible when you think about it. This is a project that started as a book that I was writing, that I've been working on and off for more than 4 years now. And all along, once we started thinking about it as a TV show, the idea was to have the opening episode be on vaccines, mostly because the invention of the smallpox vaccine and variolation before it was one of the first major breakthroughs that really extended our lives. And then it turns out we're having this conversation in the spring of 2021, and vaccination campaigns are literally the most important thing that is happening in the world right now. So we're nothing if not timely. And we've tried to pack as much as we could into the TV show, but with a story that's as complex as this one, that's so tied to events that are changing on the ground day by day right now, we thought it would be a good idea to have a series of conversations after each episode where we can dive kind of deeper into the issues raised by the show. And we'll be doing 4 of these conversations in total. Each one will go live after the PBS broadcast on Tuesdays at 8 p.m. Eastern. And we're incredibly lucky to be starting off this series with 2 extraordinary guests. Dr. Anne Schuchat is the deputy director of the CDC, a role she's held since September of 2015. Dr. Schuchat has played key roles in the CDC emergency responses, including the 2009 H1N1 influenza pandemic, the 2003 SARS outbreak in Beijing, and the 2001 bioterrorist anthrax response. Globally, she's worked on meningitis, pneumonia, and Ebola vaccine trials in West Africa, and conducted surveillance and prevention projects in in West Africa, and she's conducted surveillance and prevention projects in South Africa. She's currently at the forefront of the CDC's response to the coronavirus. And then Dr. Bruce Gellin, who is president of Global Immunization at the Sabin Vaccine Institute in Washington, D.C. Prior to joining Sabin, Dr. Gellin served as the Deputy Assistant Director for Health and Director of the National Vaccine Program Office at the U.S. Department of Health and Human Services, where he oversaw the National Vaccine Program. Dr. Gellin also served as a technical and policy advisor to the World Health Organization, focusing on influenza vaccines and global issues of vaccine hesitancy. And he's been a longtime advisor to the Extra Life Project itself, for which we're very grateful. Bruce and Anne, thank you both for being here. We really appreciate it.
It's a pleasure.
It's a treat to be with you, Stephen. Thanks.
So, so many things to talk to you both about, but I think when I watched that vaccine episode, when I can watch it, I've seen so many times, I'm a little sick of it, but when I try and watch it with fresh eyes and when I talk to people about it, I think, one of the moments in it that is really the most powerful is that kind of closing sequence about smallpox eradication, and that conversation with Larry Bryant, and the kind of scale of that project and the achievement of it, how remarkable it really is. And I was wondering, watching that again, you all obviously know way more than I do even about the story of smallpox eradication, but what are the lessons from that for us today in the middle of the crisis we're in? What can we learn from that epic achievement in the 1970s?
Maybe I can start. It's an epic story, and it's so inspiring to think of eradicating a disease as terrible as smallpox and what that means for every generation thereafter. And I think a key lesson for me of the smallpox eradication program was having a big, bold goal and bringing the world together around that. The idea of, global solidarity and commitment, and then just the tens of thousands of people that you needed to make it happen, every one of whom is embracing that goal and problem solving every day to make the world better in the future. So it's just inspiring in terms of its ambition, and then in terms of its execution, it's unbelievable.
When you rewind the tape and look at the decision to go for eradication, it's surprising that people bought into it, given how complex it was, given how audacious the goal was. But I think the progress that had been made to date said we can do this. And as Anne said, the idea that you could bring people together, bring the U.S. and the Russians together in the middle of the Cold War to come up with a goal like that was quite something. But beyond that, and I think that's what we're learning today, is the massive amount of logistics that it takes to try to think about how you're going to organize this. And while the logistics are an important part to make sure that you have the right vaccine at the right place at the right time, at the end of the road, it's that last mile. That if you don't have the communities as part of this, it's a pretty difficult slog to try to get where you're going, and the need to try to keep that in mind from the beginning, to keep the end of that road, not just the goal of eradication, but the people you're trying to reach at the beginning, to have them be with you.
Well, here we are in the middle of an enormously complex logistical operation that, on some level is much larger in a way, because it's purely global. We'd eliminated smallpox in a lot of the world by the 70s. Now we're dealing with a virus that is, yes, less lethal, but more widespread in the form of the coronavirus. So as you've been watching and participating in, playing a leading role in many ways in this whole vaccine development and rollout process, what are the key things that has been the most kind of positively surprising, right? What is of the whole kind of last year of developing and then getting shots in the arm of the COVID-19 vaccine? What's been the most encouraging part of that process? I'm curious what both of you would say about that.
Well, I can start again. I think that the mRNA vaccines, at the beginning of planning for vaccine development, there was a wise decision to, have a diverse portfolio, and some of the approaches were tried and true, and some of them were novel. And the incredible efficacy and actually safety of the mRNA vaccines in frail elderly in nursing homes. It's, Bruce and I have worked on influenza for a long time, but to have a technology that worked that well and that could be brought to scale. So, to me, we have so many vaccine development initiatives where it's really decades of troubleshooting and trying to figure out, how to overcome the challenges of obtaining true protection to get, 94, 95% clinical efficacy in people who are not, 20-year-olds is really impressive. And then to simultaneously produce to the point where we essentially have administered hundreds of millions of doses already in the US, that in a period of time that is, we could never have imagined this, 20 years ago.
Yeah, Anne spoke about the broad portfolio. And I think, to me, a related part of that was anybody who thought that they had an approach to this or had a solution to this was in the game. Hundreds of ideas bubbled forward. Now, a year later, we can see that there are 125 are in some stage of either approval, authorization, or in clinical trials. So there's still a lot to come. But the idea that we could have this much science, this much ingenuity come to the fore for having many different opportunities to try to see, do we have an approach that will work? As Anne said, everybody was surprised how successful this was. When FDA set the initial bar, they said, okay, if it's at least 50% effective, we'll consider it. Then they open up the box and voila, nobody expected that, particularly, as Anne said, in populations who traditionally don't have the best immune systems to be able to develop the best immune response. And this has been a game changer. So I think that has been a piece of it as well. But not to forget the collaboration and the ingenuity going forward. And we still have things yet to see. There are vaccines in various stages of clinical trials. We're going to have to see how they perform, what their feasibility is of both manufacturing and delivering. So I think that we're at the beginning of the story, not the end of the story, as far as the ingenuity and innovation of vaccine research and development.
One of the things that's funny, when we were shooting the vaccines episode, we interviewed Dr. Fauci, who briefly, appears in that episode. And it was the day that the initial efficacy trials had come back for the Moderna vaccine, and they were like 95 or whatever it was. And he was bouncing with excitement. He said at some point in the conversation, which we did put in the show, but he said, I've had a lot of bad breaks in my career with things that have gone wrong, but man, we got a great break. It was amazing.
No, the amount of good news was incredible. And in fact, that was, and I'm sure Anne had the same feeling. Sooner or later, the ball is going to drop here, because we've seen too many times where things look promising through development, and then when you look at them and how they actually perform, it's not quite what you expected. That was the case with these. They looked promising. We saw the immune studies. We saw the press releases. And we're keeping our fingers crossed that this would actually achieve what we had hoped it might and not be a disappointment.
And it just makes you think about when you try, you can really do a lot. I think that sometimes there's such a big hurdle to take on a vaccine development or a prevention effort. But, this was really astounding. I remember in 2009 during, the influenza pandemic, a press event where, in the summer we were saying, we don't know if we'll be able to make a vaccine, if it'll work, if they'll be able to manufacture it, if it'll be safe, and that was for a type of vaccine we'd been using for decades. We just didn't know, will we be, and this was really the same thing. And then just those first results were stunning. And then the ability to scale and deliver, which is 99% of the game is delivering. And so the idea that, we've been averaging around 3 million doses administered a day in the United States, which is, extraordinary.
I go and I check the update of how many doses have been delivered each day. That is on a bunch of websites. I think the CDC has that on their website, and it's it's so exciting. It's so much better than baseball scores or the stock market. You're actually following a number that is really lives being saved. It's extraordinary.
You also see how excited people are when they get it, which is really amazing. That just it's a selfie moment, or it's a celebration, a huge relief for so many people.
I want to say that speed has been an element of all this, and I think some of that speed there's been some skepticism about that speed, and we can talk a little bit more about that. I think maybe we didn't do the best job of communicating how much of the technology was around for decades and it was maturing and it was available at just the right time. It's not like somebody found this on a shelf somewhere and said, okay, now we have it and it's a brand new thing. So it turned out to be, it just shows the value of investing in this kind of science over a long period of time, because you don't know when you're going to need it. But similarly, as you said, with the vaccination program, we didn't think we'd be able to accomplish that on the complex logistics of vaccination. It was a bumpy road, one of Anne's favorite words, early days, but now it's smoothed out quite a bit. At least in the United States, watching the states try to figure out how best to get vaccine, have vaccine be available as quickly as possible. It's now smoothed out quite a bit. We're at a different inflection point. But again, where we are now, within 18 months of having this started, is something that nobody thought we would be in this kind of position.
Well, I want to ask you both about the kind of what has potentially been disappointing about this experience, but you brought up speed. So let me ask you this first, Bruce. How do you counter the argument that some have made that given the scale of the pandemic and given the risk of variants, and given the early feedback from phase 1 and phase 2 trials, should we have gone even faster in approving the vaccines and getting them into people's arms, given that we're a race against this virus spreading around the world and potential variants that might be even more lethal?
No, I mean, the issue is when you chase a virus with a vaccine, the virus is going to win. So I think the more we can shorten that time, the better. At the same time, we have to make sure that we have the best evidence to be able to do that. Again, we had to make sure that we had vaccines that would perform as we thought they would, both in terms of efficacy and safety. The fact that the trials were able to be conducted as quickly as they were is testament to actually how much disease was out there. Often it takes a long time because you have to see whether or not people who've been vaccinated are indeed protected. When faced with so much infection, it was relatively quick to be able to get to that answer. So I think that while everybody wants things to go faster, I think at this point, where we were, I think that was better than we could have done. In the future, I think this has to do with the way we understand clinical trials, the way we design science. If we had better markers to know who was protected as been vaccinated versus waiting to see who gets infected, that would greatly shorten that time period. And that's something that I think is part of what will be the new normal for vaccine research and development.
I did a conversation with I'll tell you 1 second, Anna. I did a conversation with Andy Slavitt in the spring. We were talking about going through the trials, and I was saying, it's interesting. All of a sudden, everyone is aware of the process of kind of drug testing and the medical kind of apparatus for clinical trials and RCTs and all these things. And Andy Slavitt said, it's like the whole world is living in the middle of the scientific method. Finally, for the first time, they're experiencing it, firsthand, and it's a life or death matter, which is. It's an education for all of us in a way who don't live this and breathe this stuff day in and day out the way you two do. But sorry, Anne, you were going to say something.
Well, that just makes me want to say something different. I feel like the whole world has become epidemiologists, and people are looking at the data carefully and arguing about it and trying to figure out what the patterns mean. And, in a way, that's a really great legacy of this terrible pandemic. The more people are thinking about data and how it can inform actions and what it means to me in my daily life. But for sure, the vaccine development and trial and approval process and administration process is so much more familiar to people. I think people don't take vaccines for granted right now because it's just a high value commodity, really.
But to Andy's point about living the scientific method, I think there's a flip side to that we need to acknowledge. We see, on the science side, we see this all the time, where you see a study that says something one day and the next week there's something that says the opposite. But this tsunami of science is pretty hard to digest. And I think that people get numb to that because you don't really know what to do with that and how you manage that. How do you then act on that? I think there's been some criticisms of that to think, well, you said this last time, and now you're telling us this. Frankly, again, among us, I will say the thing I think we're missing this time is what Anne did for us last time. Was when this starts up, the first thing is you hear of the head of the CDC steps forward and says, "Here's what we know, here's what we don't know, here's what we're doing about it, here's what we think you should do about it, but also know that as things change, that cascade might change as well, and we might tell you different things." I think that's probably one of the things that could have done better at the beginning, because people end up then being confused when the message seemed to be different and the recommendations seemed to be different when the science was different and warranted that.
Yeah, I think that an emerging infection is all about dealing with uncertainty, and the way that it evolves, it can be a blip and disappear, and then you're blamed for overreacting. It can be, the worst thing in 100 years. And then the question is, were you out of the box strong enough? But the way that you talk about it and the way that you listen are critical. And, I think all of us in public health are trying to listen, and we're trying to talk. And it hasn't gone as well as we would have liked this past year and a half, at least in our country. I think every country, every state, every jurisdiction has been dealing with this, and tragically, India is dealing with it today, and other countries, are having challenges as well. So, I just think, that communication piece is so critical. It's not the afterthought; it's the first thing.
That segues perfectly into the question I wanted to ask, which is what, for each of you, what do you think has been the biggest disappointment of this process that really should have gone better, that seems tragic to us now?
Well, I think there's really, from the beginning in the United States, we ended up with two realities of, whether the virus was bad or not, and whether it was worth taking actions. And we basically had a false dichotomy between health and the economy. So I think that began with an argument about masks, and then fed into arguments about vaccines. I think that the concern about the virus, as more than 500,000 Americans have died, and as everybody knows somebody who's been really sick with it, has perhaps affected a more of a shared reality. But I think that the sources of information and trust were so different for Americans that we lost a lot of lives, I think, because of that.
Yeah, I'll say a similar thing in a different way. I think the politicization of this was a surprise, and that was the disappointment, because that just changed the whole set of behaviors in many places. So that was a surprise to me. I guess maybe I should have been surprised, having lived in Washington for a long time and seeing how these things play out. But the degree to which that played into it, with almost every move, that then became part of the narrative.
We were talking about uncertainty, and it's so, to me, the other lesson for ordinary folks going through this is it forces you to think about risk and uncertainty on such a day-to-day level. I mean, we live in an apartment building here in New York, and so in the early days of the outbreak, when the national epicenter, if not the world epicenter, was all around us here in Brooklyn and Manhattan, the single biggest question about the safety of my family was, what is the risk of a coronavirus infecting somebody in an elevator? that was the one choke point that we felt safe inside our house, and we could go outside, and we knew we were pretty safe outside, but there was this little 5x5 box that we had to get into to get it out of our house. And it was just what is the risk? And this whole year has been about creating risk modeling on a governmental level, and then on a very personal, and so many interpersonal conversations with your friends where people have different kind of risk tolerance. And so I wanted to ask you about this, Anne, in terms of your role and the CDC and other regulatory bodies. How do we make those complicated decisions? We've just been in the middle of this with the J&J vaccine pause, which, as we're recording this, has been unpaused. But are we? How do you make those calculations?
Yeah. Well, assessing risk and managing it is essential. That's public health, and that's certainly the work that we have been doing around the J&J or Janssen vaccine. And I think the way that it was handled really took, an incredible effort, but a very intense risk-benefit analysis. Can we learn as much as we can about safety signals and potential concerns? Can we learn as much as we can about the cost of not giving the vaccine in terms of what additional COVID cases and their complications will occur? And, with a pretty intensive effort, that equation became, was those data were presented to a group of independent experts, and pretty much unanimously, the benefit greatly outweighed the risk. But then it was, well, how do we mitigate the remaining risk? And that's about communication, education, and so forth. But, you can't do that for everything. For something as big as a safety signal of a vaccine, you're going to do a very extensive risk-benefit analysis. But each of us in our day-to-day life, you're looking at the elevator question of what I'm doing at the grocery store, certainly, the difficulty of not being with loved ones in nursing homes or in the hospital, those intense discussions are, you're making decisions every day. And I think in public health, we're trying to get the best information to people. But you have this extra thing with a communicable disease where it's not just about me, it's about the people around me. And what I do can be dangerous for others.
it's an interesting way in which, on some level, some of these health decisions, like, we don't want them to be politicized in the way that we've been discussing. But on some level, your view of the world, your political view of the world, your sense of belonging to a society or not, is about the kind of the circle of risk and of hazard that you're concerned about, right? And some people have a very narrow, they're just concerned about their family, and some people have a broader societal concern or a national concern or a global concern, right? And that's the one place where kind of science and public health and epidemiology kind of collide with politics unavoidably, because people do have different circles of moral concern. And I think that's one of the things that kind of bubbled up a little bit in the past year that has made it so challenging in ways. People are like, well, I'm safe, my family's safe, the rest of the world isn't my concern. And that you have to kind of get people to widen their circle to get them to think differently about it.
I think that's why, and particularly that's where an infectious disease is different than your own assessment of risk taking, whether you're going to ride a motorcycle with or without a helmet or at all. That's different. So because with an infectious disease, there is that risk that is presented to others. So it's not just the decisions about your own behavior and say, I'm gonna do what I want. It's my life. I can do that. So I think that's where that's where we've seen this in a number of places with infectious diseases, going back to the days of when quarantine was first invented, created to try to mitigate some of these. But part of this is, and just to talk about the J&J vaccine that Anne mentioned, is the risk perceptions of things that are new, novel, exotic. It was quite rare, but really quite esoteric from a medical standpoint. And people don't know how do you manage that, because it is a new disease, it's a new vaccine, and this risk that nobody had heard of before. So that gets magnified in contrast to risks that we talk about more routinely. I'm not sure that the analogies of winning the lottery, getting struck by lightning, I'm not sure how much that helps people. I heard Francis Collins, it was this weekend, talking about the risk of aspirin. And while we know the benefits of aspirin, particularly in people who have heart disease and preventing things, outweighs that risk. But if out of 10,000 people, there are 250 people who some cardiac event will be prevented, but 40 people who have a serious bleed because of aspirin. So we're sort of used to that. We deal with those kind of risks all the time. We don't think about them, but these new and novel ones get our attention in a very different way.
Yeah, I think.
Yeah, the metaphor I was using is. Oh, go ahead.
Well, I was going to say that things that are new are intrinsically scary to many people. To other people, they're like really cool and neat. So a new vaccine, for the science nerds out there watching our show are, great, line me up. I want to be first in line, like people with a new iPhone or something. But for most of the world, that new product that's about my health is not something I want to be the test case of. I want a lot of people to get it first. And that's one of the things that I think is really critical in our communication about the COVID vaccines. Is like hundreds of millions of people have gotten this vaccine around the world right now. In the US, 140 million people have been vaccinated and 230 million or so doses have been administered. So while it's fast in terms of a year and a half since we first knew about this virus, there's a lot of human experience now. But again, each of us makes those personal, brings our personal values to risky behavior and to protective behavior and what it's worth to us. But I do think the issue of an infectious disease in this case, it's not that anonymous person on the other side of the world that my behavior might affect. It's my grandmother. It's somebody in my family. I'm a healthy young 20-something. I could be bringing something back into the home or to my relatives or loved ones that I'm not even going to feel and that could kill them. And so I think that's where, to the most part, we did see a shared sense of responsibility and people reducing their contacts and wearing masks and really trying to protect each other. And I think while there might have been a lot of coverage of the people that weren't doing that, most people were doing that when the risk was imminent.
And I have to say, it's been great to see the messaging over the last month or two. In fact, there was just today something released about vaccinated people pretty much not having to wear masks outdoors other than at sporting events or something like that, and in major crowds. And so that sense of getting the message out of like, these are all the things you can do. Again, like I went, like after I was fully vaxxed, I went and drove down to DC and had dinner with my parents, like unmasked, and it was like unbelievably moving, and I was like, this is this freedom I've gotten back. And so getting that out there is obviously, it's been great to see. But I did want to ask you, Anne, this is a perfect segue into this. So we're shifting from vaccine scarcity to vaccine surplus, and the challenge of the next 3 to 6 months is going to be getting the vaccine hesitant and maybe even the anti-vax community as much as possible, getting them vaccinated. So what's the best strategy for engaging with them?
Well, I don't really like the term anti-vaxxers because I think it's really important to understand where people are and to meet people where they are. And I think with the COVID vaccination, we've really seen that people have had questions, which are really understandable. We weren't even hearing about this disease 2 years ago, and the vaccines, that understanding what questions people have and how do we answer them. Sometimes it's, information that people need. Sometimes it's knowing people who've gotten the vaccine. Data can be helpful for some people, but the messenger is actually more important for a lot of people. That there's somebody I know and trust has done the homework and figured this thing out and can give me their download of what they think about this. So I think a real theme right now in our vaccination efforts is meeting people where they are and understanding if it's bringing the vaccine to the homebound or getting into the communities that don't have pharmacies and that don't have mass, community centers. Some people feel much more comfortable getting vaccinated in their doctor's office. And the presentation of this vaccine, most of the vaccines, except for the J&J, were, these huge big trays of many, many doses and needing very much cold storage that wasn't so accessible to have in doctors' offices. So I think that the next phases are really expanding the access, making it easy for people, and getting the trusted messengers to do the talking and not telling them what to say, sharing the information with them, but letting them listen and probe and ask the questions and then, talk to their communities. So I think that I do think that attitudes have been pretty dynamic this past year with nobody wanting the vaccine when we were just before we had the results of the trials, and then increasing confidence or interest in being vaccinated. Obviously, ongoing questions about safety, and we are committed to being open and honest with what we find out. But I think right now it's really a question of trust and proximity, access and messaging.
Yeah, meeting people where they are is both a geographic and a philosophical approach. And I think we need to keep that in mind for all the reasons that Anne's mentioned. I think it's also important to try to tease out. Vaccine hesitancy has become a very common term, and we need to make sure we understand what the right diagnosis is. If you say, as a clinician, if you don't have the right diagnosis, you're not going to have the right treatment. So making sure that we understand what is it about this person, why they didn't get vaccinated. Was it some issue that they raised about the way the vaccine was produced, or is it because it was such a hassle to get a reservation they just gave up? So I think trying to sort that out and addressing the needs that individuals have will go a long way towards helping that. But let me ask one other thing. As we get into, as we get, and I don't know if you want to shift to this yet, but as we get into this situation where we now potentially have more supply than we have more demand, that's a U.S. statement. And we need to take a step back and think about what that means globally, because it's quite a different set of numbers when you look at the access that people in the rest of the world have had, with a few exceptions in places like Israel. So we need to take a hard look at that and to make sure that we're acknowledging the needs elsewhere. India is what we're seeing in the past couple of days, but there are likely to be other, quote, hotspots where vaccine is going to be needed. And that needs to be addressed pretty seriously, not just by the United States, but by everyone who can move vaccine around the world.
it's such an important point. I mean, I think, this is again, this lesson we see again and again when we talk about global outbreaks and pandemics. They are by definition global. That's built into the actual word pandemic. And you can't solve them on a national level, right? It's just not something that you can do. And so it forces, on some level, it gets to the best of us, right? I mean, and that's the beauty of the smallpox eradication story, is that, when you see the world coming together, when you see the sharing of information in the early days just about the genetic sequence of the coronavirus and how quickly that spread around the world. I mean, you think about how long it took for HIV to be identified and for that information to circulate. It took years and years and years, and here we knew this new organism that had just been identified, and people were working on building a vaccine for it, 2 or 3 weeks after it had been identified. It's amazing. So on the one hand, you look at it and you say, this is so inspiring that we can do this, but you can't just look at the national situation and say, well, if we can just get this control here in the United States, we'll be fine. We don't need to worry about India. We don't need to worry about Brazil. And that's it. You can't walk away from that.
But I think that while there's a lot of discussion about sort of the moral purpose of doing that, I think that there's also the public health reasons to do that. And particularly as we've now learned about variants. I will say that variance is one of those pieces of science that we had to learn along the way. 6 months ago, we thought, oh, this is a different kind of virus. It's not like flu. It's not going to mutate. Well, guess what? And now we see that the more these viruses proliferate, the more there'll be errors in their proliferation that leads to these variants, and we're going to see more and more of these. So there is this very clear global public health reason to make sure that the virus doesn't continue to ravage communities and to cause more and more viruses that will then cause more and more of these variants.
Yeah, I mean, we're all in this together. I have to say, during the past year and a half, the United States seemed so big to me because things were happening at different points in different places. New York City, hot spot. And then, we had the Midwest, the South, just, things were very different in different localities. But the world, on the one hand, is enormous in terms of the vulnerabilities and the challenges. But, I think one thing about vaccination is we have had global vaccination efforts before, and there are, expanded program on immunization throughout the world, routine childhood vaccines. And, we have something to build on, a legacy of smallpox, a legacy of the polio eradication initiative, a legacy of, expanding childhood immunization around the world. And we're all vulnerable until everybody's protected. And so I think we have a lot to do going forward. It's obviously a more promising time right now in the United States and a darker time in India. But if we don't control this disease around the world, we really, it's to our own peril, not just to our humanitarian interests.
One last specific question about the future to you, Bruce, and then I'll entertain any kind of closing thoughts that you both have. But we've seen this breakthrough with mRNA in this cycle. I'm curious about what's the next big advance in the long history of vaccines that we can look forward to and try and work towards. And I know you've been interested in this idea. We first met in this context of some kind of universal influenza vaccine. Is that something we should be steering towards as the next big advance? I'm sure that you'll get 100 answers on what the next big advance would be. But I think clearly what we've seen with this virus, the coronavirus, and particularly with now the spinning off of the variants and the risks that they create, in fact, maybe sort of re-sparking a new pandemic, if you will, if the immunity that we have from either disease or vaccine isn't enough to prevent us from the next one. That was the model for influenza as well. And as I mentioned before, chasing viruses with a vaccine, the virus is going to win.
And we have to try to think about developing a set of vaccines, particularly for these emerging infectious diseases, including the infamous disease X, the one we don't yet know about, is how we're going to make sure, or how are we going to be ready for that and to have vaccines available before they emerge or as soon after they emerge. So in chasing them, we're not going to be in a losing proposition again. So you and I have talked about a universal influenza vaccine, the idea that you could have a vaccine that could prevent all flu, just not that we see every season, but also an emerging virus that could spark a pandemic. There's been similar talk, not surprisingly, for the same type of vaccine for coronaviruses, variant proof, if you will. I think those are two of the things that we're going to need, for which we're going to need to marshal efforts to get there. The science isn't easy, but we recognize that, as Anne said, when you take a hard look at things, you can invest in some of the science, and with that collaboration and getting people from different fields to help you solve that problem may get there. I think those are the kind of things we need for game-changing, particularly for pandemics. And I think that we now have a co-traveler with a universal influenza vaccine to do the same for COVID, but also knowing that we shouldn't be too confident, that we don't know what might come next. We have to be prepared for something we don't know about so we can be able to be reactive and responsive as quickly as possible.
Well, I just want, just as a kind of closing comment and then open it up to both of you, I just value both of your work so much. And when I got the shot, I mentioned this in the show, when I got the first dose, which I got at a racetrack. Some people want to do it at a doctor's office, but in New York, I went out to Queens and got it at a racetrack, which is one of those things you don't expect to have happen in your life. But I was so, having made this program and written this book and just been living in this world of this history, I was so moved by it. And, I kind of teared up a little bit. And it was really the thought of all of the work, right, that had gone into this moment for me personally, but all, dating all the way back to the variolators and Edward Jenner and, the people who fought for this and Jonas Salk and Sabin and all the heroes and the smallpox eradicators. And I don't know, I feel like if anything good comes out of this, it is an awareness of the importance of that work and how it goes along kind of quietly in the background until one of these things flares up and suddenly you realize how much support we get from this kind of infrastructure. And so that was part of the mission of making the show. We didn't realize we were going to be in the middle of a pandemic when it actually came out. But to me, that's an important lesson of all this.
Well, let me just say I think that how you did such a vivid portrayal of smallpox. People will have no idea until they see this what that was all about. They may have read about it, they may have heard something about it or studied somewhere, but I think you made it real, and the kinds of angst that families would have for centuries in trying to protect themselves and their families and their communities from the ravages of smallpox, and now is eradicated, gone forever into the future. I think in a way that's the immunization, maybe the metaphor for prevention. The perfect vaccine is when you're vaccinated and nothing happens. And so I think that's where it's not a headline when nothing happens. So I think that what we're seeing now, and hopefully as we start to see the impact of vaccination on the curve, will people recognize the power of vaccines to create nothing happens.
Yeah, I think the beginning of your film shows the really horrific photos of what smallpox virus could do to a person. And I mentioned my husband watched the film with me and hadn't seen, what smallpox really looked at. And it's shocking and it's stigmatizing for those who survive. And it's gone. And you think about what it took to have that not just disappear, but be eradicated. It was really difficult, but it succeeded. And I think that you could say, well, smallpox was a disease people could see, and we have these other viruses that aren't so visible. But I think one of the, currently we have this amazing vaccine science and technology, but we've also got amazing journalism and media that has made visible what COVID is doing to people. The stories and the experience that millions and millions and millions of people have had. And hopefully the enemy is bad enough that there's a shared sense of needing to tackle this one. I do think that the science and technology are extraordinary and are going to carry us a long way, but we really need a shared sense of that enemy is the virus and not each other.
Well, thank you both. Thanks to Drs. Bruce Gellin and Ann Schuckett for joining us for this initial conversation. It's been an amazing beginning to this series. If the other 3 conversations are as good as this, we'll be in good shape. We were really grateful to the CDC Foundation for their help in putting these together. It's a nonprofit focused on saving and improving lives by strengthening public health protection through partnerships across the globe. Together, our impact is greater. I mean, that's exactly what we've been talking about all through this conversation. We'll be back with a new conversation following the second episode, which is on medical drugs and really the story of penicillin and beyond, which airs at 8 p.m. on PBS Tuesday, May 18th. And in the meantime, wherever you're watching this, there are links below where you can buy the book, get educational materials from the Pulitzer Center, and learn more about the topics and our guests that we've covered in this conversation. Thank you, Ann and Bruce, for being here.
Thanks a lot, Stephen.
Thank you.